Hello, everyone. Good morning, good afternoon, and good evening. Welcome to the second webinar in a series co-hosted by Family Planning 2020 and the International AIDS Society on leveraging differentiated service delivery for HIV treatment to strengthen contraceptive care. My name is Dr. Anna Grimsrud, and on behalf of the IAS, including the IAS Educational Fund and the DSD Initiative, as well as Family Planning 2020, I'd like to extend a really warm welcome to all of you today for this webinar, which is titled Family Planning and HIV Integration, Policy Priorities, On-the-Ground Realities, and Opportunities Ahead. So now that you've all joined us, I just want to go through two quick housekeeping items. The first is that we'd really like to know who's joined us today. So please go ahead now and access the chat function and maybe share some information with us. We'd love to know who you are, who you work with, and what country you're joining us from. And then secondly, you'll see that in addition to the Q&A, in addition to the chat function, we have a Q&A function on this webinar today. And we've got a really amazing group of people behind the scenes here who can answer your questions about sexual and reproductive health and HIV integration. So please feel free to engage us today through that Q&A by asking your questions. This is the first way in which we hope to engage you, our audience, and there's a couple other ways as well. So please be ready to talk with us. So in terms of the next slide here, we really do want to get your thoughts and opinions. And so in a few minutes, I'm going to ask you to share what barriers exist and what you need in order for sexual and reproductive health and HIV integration to be made a reality in your setting. So I just want to plant that seed now and get all of you thinking. So what do you need and what are the barriers at the moment? So to get your thoughts and opinions on these barriers and needs, we're going to engage you on an exercise on menti.com. So we're going to need you to go to the website menti.com in a few minutes. I just want to preempt this. So you're going to need to open a web browser, either on your phone or on your tablet or in another window, and go to menti.com and enter a code. We're going to do that in a few minutes, so just be prepared for that when it happens, because we'd really like to make some beautiful word clouds with you today. So my job is now to introduce the agenda for this 1-hour session. So here we are in part 1, and we're going to do some introductions, share some thoughts on the first webinar from this series, as well as some reflections from yesterday's World AIDS Day. And we're also going to hear a really exciting global call to action. In the second part of the webinar, we're excited to hear from an illustrious panel of discussants on their experiences and their hopes for the future around SRH and HIV integration. So here in part 1, hello, I'm Anna Grimsrud, and I'm joining today from South Africa, where I live and I lead the differentiated service delivery portfolio of work at the IAS. I'm honored to share this virtual stage with Beth Schlachter, who is the Executive Director of Family Planning 2020, and she's going to be providing what I consider to be the plenary presentation of the session today. Also, as flagged here, if you hit next, we're going to make these word clouds on menti.com because we want to hear from you, our global audience. So get ready for that. Following Beth and I, we're going to hand over to Mitchell Warren from AVAC to lead a discussion with this group of discussants. And these are going to include perspectives from activists, advocates, implementers, researchers, and critically as well from recipients of care. So be ready to ask them your questions and hear from them in the second part of this webinar. Yesterday, World AIDS Day, marked 6 years since the global fast-track targets for HIV were launched. The global goals were ambitious and set targets for HIV treatment in terms of reducing new infections, as well as eliminating HIV discrimination. And by the end of this year, we were to try and ensure that 90% of people living with HIV knew their HIV status, that 90% of those people were on antiretroviral therapy, and that 90% of people on treatment had achieved viral suppression. However, yesterday, we heard from UNAIDS and WHO and others how the 2020 targets would not be reached. In summary, the World AIDS Day report from UNAIDS highlighted that the global HIV response was off track even before COVID, and now COVID-19 further threatens the progress and the gains that we've made. Relevant to this group and this webinar, these are the new top-line targets that were announced for 2025, as part of a roadmap to get us back on course and course correct so that we can meet the HIV 2030 targets. You'll see here that there's actually now 6 95s, so 3 additional 95s, and highlighted in green is that 95% of women are accessing HIV and sexual and reproductive health services. So this is a new top-line target. Further, the UNAIDS report highlighted that sexual and reproductive health and rights are within the 2025 targets, and they explicitly called out family planning, STI services, and comprehensive sexuality education. So just to say, we're really excited to have you here today because we want to talk about this and see that while we know that sexual reproductive health and HIV integration has long been the goal, we haven't always met this reality. It hasn't been our reality, it's been more of an aspiration. And so what can we do going forward? So I invite you now to all go to menti.com. And when you get to menti.com, you'll be prompted to enter a code. And that code, as it appears on your screen, is 8759630. So I'm gonna go ahead and go to menti.com and type in that code, which we are going to see again right now. So remember that code is 8759630. So in your setting, what barriers exist for SRH and HIV integration? And you have the option to enter 3 things here. So what are the barriers? I'm entering my answers, and I can see that 1 person has voted, but I hope other people will too. So remember, you need to go to menti.com, and the code is 8759630. Wow, this is excellent. So you can see here that the size of the word represents the number of kind of votes that it's got. And coming up so far, we see there are some big barriers in regards to stigma, political will, and lack of awareness. I also see silo coming up in many ways, provider bias, social norms, separate health systems. We've got a lack of method mix. We've got a heavy lift for too few. We've got cost barriers and cultural barriers. So many different barriers exist. And I'm sure if we had more time and if I could read more clearly, we would see that these would group in some areas. We've had 38 of you vote so far. I'm just going to leave it for another 30 seconds or so and see what else we have. Apologies to those of you who are joining and need translation services. Unfortunately, this webinar today is just in English, but some of the resources we have will be shared in French as well. So the big takeaway here is that stigma is the biggest word, and we also see political will, social norms, and provider bias as barriers. So let's go ahead and go to the next question. So if these are barriers, what do you need to achieve SRH and HIV integration in your settings? What's missing? What's the piece of the puzzle that would allow for this to happen? Again, what do you need to achieve SRH and HIV integration in your setting? So hopefully those of you who are on menti.com and have used this code can answer. And while you're all answering, I'm going to invite Beth to join me on the virtual stage by turning on her camera. And Beth, maybe as these answers are popping up, you'd like to also give your thoughts on what you think is needed to achieve SRH integration and help me with some of this word cloud debrief. I see funding, political will, and training coming out already.
And you know, it's what struck me too about the last slide and this slide is how both as people who need services, people who provide services, and people who shape the service delivery environment. It's amazing how we both can be compassionate and empathic and provide what's needed, but also we just get in the way. And, and it's
That's
the
true.
people-to-people connection, like on this call, that are going to help solve these problems, because they're built by all of us and they exist within our, our families, our relationships with the community, and then again with social and service provision. So, I just, as much as we see the problem, I also see that we are our own path to solution. And it's these kinds of conversations and the work we'll do together that will help get us there.
Absolutely. So thank you to all of you who've participated in menti.com. Please do feel free to use the Q&A with more questions. And we're going to have some polls later on, but for now I'm going to turn over to Beth to share with us this really exciting global call to action. So thanks very much, Beth. Over to you.
Thank you, Anna, and thank you to all of our IAS colleagues. On behalf of FP 2020, we're so truly thrilled to be partnering with you today. It's such an important conversation, and this is the second webinar in a series that we've done with IAS and FP 2020. So again, we're just so thrilled with this partnership. For those of you who don't know me, I'm Beth Schlachter, Executive Director at FP 2020. For the last 8 years, we've been working together with our partners across the world to support women and girls to decide freely and for themselves when, whether, and if they want to have children. I truly want to thank everybody who's tuned in today and who has worked with us every day over the last 8 years as part of this broader global movement. I'm pleased to continue today's conversation, which will draw together not only another conversation we had in mid-October on a specific pathway and method for SRH integration, but also build on a webinar we did in July during the AIDS conference, where we brought together HIV and FP communities to discuss together 1 year post-ECHO after the trial to see what progress we've made and what gaps remained in moving things forward. So we'll talk a lot, as we talk a lot today, we know more about the impact of COVID on all of us, but we also know how profoundly important it is to continue to deepen our advocacy for truly integrated services. And I think those word clouds, Anna, help to pave the way that as much as COVID has changed things in terms of the specifics of an operating environment, it's really just heightened and put a spotlight on challenges and problems that already existed. But I think that spotlight also, I hope, will guide us towards solutions as well. So at FP 2020, and for those of our colleagues in the family planning sector on the call today, we each believe that every woman and girl has the right to high quality, voluntary family planning and contraception, regardless of her HIV status. And yet for far too many women, especially young women and adolescent girls, they are simultaneously at risk for both unintended pregnancy and HIV and STI infections. And we all know that silos continue to exist between SRH and HIV service delivery, yet we need services to reach everyone. The more we draw together, the more we understand that we each draw from common principles, even if it's not always a common language. So next slide, please. So before I have the honor of launching the global call to action, I thought it might be important to just quickly review what exactly we mean by rights-based care for both family planning and HIV. FP 2020 and many of our colleagues on the call today have long been engaged in a process to advance rights-based family planning. But for those of you who may be less familiar, we wanted to provide just a quick reminder and why it's important and why it matters for today's conversation as we seek to break down these silos between family planning, SRH, and HIV communities. At its most fundamental, family planning policies, plans, and programs can only be truly considered rights-based if they're designed and implemented to respect, promote, and fulfill the principles that are listed on this slide. While these principles encompass 10 different dimensions of family planning, at their heart, they can be boiled down to this. They put the woman, or the girl, and her needs and her rights at the center of planning, programming, and implementation. And in the end, this leads to better outcomes, a better health system, and a more sustainable process for everyone. The same can be said for HIV, where in recent years, a differentiated service delivery approach to providing HIV services has been adopted in recognition of the diverse needs of people living with and vulnerable to HIV. Differentiated service delivery, or DSD, which you'll hear a lot about today, puts the person at the center, adapting the when, where, what, and who of service provision. With a growing number of people living with HIV now accessing their care and treatment services closer to home and coming to health facilities only every 6 or 12 months, it's critical that women and girls living with HIV have their family planning care truly integrated with their HIV services. With all this in mind, I'm proud to share what FP 2020 and AVAC have been working on with a large community of practice, which with representatives from many of your organizations, for those of you on the call today, to call for and advance SRH integration in this particularly critical time. Next slide, please. Before we talk about what the global call to action is, though, and in the spirit of community, it's important to recognize that this call to action is the outgrowth of a diverse technical group comprising many of you who together form the integration community of practice. This group first came together last year in October of 2019, long before, well, a little before the pandemic, to try to work together to advance SRH integration and to foster more direct collaboration across the SRH community. The group enjoys representation from a broad swath of organizations across the globe, representing sexual and reproductive health organizations, HIV organizations, cervical cancer organizations, and it's led by FP 2020 and AVAC. We're also happy that the IAS has signed on to this call to action. In recent months, and as the impact of the COVID crisis became ever more clear, this group also intuitively understood the opportunities for the global health community, from normative agenda setters all the way to providers and beneficiaries themselves, to call for better integration. Next slide. It's with this context in mind that we launched the call to action for the provision of rights-based, client-centered sexual and reproductive health during and after COVID-19. As communities who are too often siloed, we stand together for ensuring rights-based, client-centered SRH services, including family planning, HIV and STI prevention, testing and treatment, and cervical cancer services during this crisis period and with a mind toward the future. Next slide, please. We know we can't move forward alone, and we have to do so together. And our call to action has a global cross-sectoral audience with 4 key recommendations. Our first recommendation, which of course applies to all of us, and that is that we as a global community continue to stand together to call for SRH integration, to include at a minimum family planning and the full range of contraceptive methods, HIV, STI prevention, testing and treatment, and cervical cancer services. This means, for example, over-the-counter access to contraception, including, importantly, emergency contraception, multi-month dispensing of HIV prevention and treatment tools like PrEP and ARV, a recognition of a move towards self-care and self-testing for both FP and HIV needs, promoting access to the HPV vaccine, strengthening virtual and telehealth services, and continuing and supporting task shifting and community-based health and community health workers, as well as youth-friendly services, among other effective approaches. So we know some of this is happening. For example, we've heard of efforts in Zambia, where the move to multi-month dispensing of ART medicines is already happening. But we want to see this happening more broadly and more consistently to meet the needs of the multiple health needs of women, girls, and all clients. Next slide, please. So secondly, we ask that governments and other policymakers look at their own guidance and policies and bring a call for SRH integration forward for all individuals, including and especially for adolescents and young people, for whom it too often remains difficult to obtain any method of contraception, regardless of HIV status. We've seen incredible normative guidance work from colleagues at WHO, supporting countries to make evidence-based national policies. At a country level, the most commonly adopted WHO recommendation on family planning has been to allow 3 months of short-acting contraceptive methods, allowing for easier access for women and girls. However, there's been variable uptake of the WHO recommendations that family planning substitutions during this time of COVID and limited access to services, that family planning substitutions be made when a preferred method is not available. This variability is also reflected in national adoption of WHO guidelines around HIV. While many countries in Africa, for example, have adopted the recommendation to extend ART refills for 3 to 6 months, uptake has been slower in other regions. As you can tell, we're still talking in silos, and that's where we need to move forward. Next slide. So our third recommendation. One of the barriers I'm sure will come up during today's panel conversation is about financing. Even pre-COVID, we know that donors and donor agencies often treat FP and HIV as two very separate services, even if outcomes would be improved if the entirety of the health needs of women and girls were considered together. It just makes sense. It's one body, and we should treat it as such. A call to action on donors and agencies to reduce such barriers and to break down the silos that can prevent effective health service provision and better meet the needs of all people. And our fourth recommendation. As our call reflects on how advocates can take this message forward, it fits that many of us gathered here today are members of civil society or we're advocates. We must continue to advocate for investments for SRH programs, procurement of critical health commodities, metrics that reflect new models of service delivery, including differentiated service delivery, and provider training and program designs. Provider training we saw was key because stigma pops up as the #1 word in pretty much every conversation. As COVID-19 increases challenges to reaching communities with information on comprehensive SRH, we all will need to build on our own existing partnerships, even as we build new ones, including those most vulnerable to HIV, for adolescents and young people, and to continue to advocate for and eventually track progress on governments and donor efforts. The global call to action, as well as more information about the community of practice and who is in it, can be found on this website. I hope we advance the slide for this. And this website is curated jointly by AVAC and FP2020. We would welcome more people in the community and as standard bearers for this call to action. As many of you know, FP2020 is currently in the process of transition, but we will continue to update this website and sharpen it, including based on information and products from all of you. FP2020 will be going forward into the next decade, and in January, we'll be launching the process for new commitments and our new sort of brand identity, even as we celebrate and share what we've learned from FP2020 over the last 8 years. So we invite you to join that conversation. We invite you to join our community of practice, and we'd love to hear from what you have to share for this process. In the new year, we'll be hosting another session currently under development to explore this unfinished agenda, and we'll be launching a brief developed by FP2020 and youth leaders that discusses why young people remain vulnerable to HIV and how future efforts to advance the findings of the 2019 ECHO trial can and must include a focus on adolescents and young people. And finally, we're sharing the call to action across all our social media platforms, so please join us in doing so as well, and in continuing to call for more attention to this critical issue. Now, I'm very pleased to turn this conversation over to my friend and colleague, Mitchell Warren, who's Executive Director at AVAC, to lead us in today's discussion with expert advocates from across the continent. So Mitchell, over to you.
Great, Beth, thank you so much for the words over the last few minutes, for the call to action, and more importantly, for a collaboration with IAS and with AVAC and with many others on this call and globally to highlight these issues. you know, we've all talked about integration for a very long time, but I am really proud that in the last couple of years, although we have FP 2020 in name and we have these 2020 AIDS targets that Anna described at the outset that were established by UNAIDS, that we've been able to come together in creating a vision for 2020 and ideally for 2025 and 2030 that is better and more feasible than many of the aspirational calls before. And that's really the purpose of this conversation. I'm thrilled to be joined by four wonderful advocates, partners, professionals in this integration space to engage in a conversation. And our great hope is that it's a conversation with all of you, which I realize might seem complicated with 200 people, but we are going to do our best. I will ask if we can, I know bandwidth issues exist, but for those who can on the panel, I'll introduce you. Please do, if you can, turn on your camera. But we are joined by Yvette Raphael from Advocates for Prevention of HIV in Africa, in South Africa, dialing in. There's Yvette, wonderful to see you. And I'm glad you got the same color memo I did. We have Josephine Nabukenya, who's an IAS Governing Council member based in Uganda, working with Muju there. And anyone who's worked in Uganda knows Muju well. Delighted also to welcome from Uganda, Margaret Happy, who is a longtime advocate and with Yvette was also on the ECHO Global Community Advisory group of that trial, which I'm sure we'll talk a bit about, and has been a member of the community of practice. And Helen Bygrave, who works with IAS on the Differentiated Service Delivery program. Again, I'm going to remind people, and I see many of you have already begun to do it, feel free to put your questions in the Q&A. The chat is great to still introduce yourself, but put questions in the Q&A. We're going to get to as many of them as we can. And in just a minute, we're also going to have a couple of polls to keep the interactivity going. But before we do, I want to go back. I loved Anna as she did the mentee up front on the website. I want to begin maybe just so we bring all four of your voices in from the panel to have you all kind of throw out the words you used in those word cloud exercises. What barriers exist and what do you need to achieve this idea of integration? Maybe I'll start, Josephine, with you, if I may.
Thank you so much. My name is Josephine, as introduced. And one of the barriers that we face when you talk about integrating HIV services with contraceptive care is the negative attitudes of some health workers, because we know that in most of our health facilities, due to advocacy and all the work that has been happening, there are peer-led models that are being intervened at the health facilities. So we have adolescents and young peers providing services. We have the YAPS models. We have the CATS models. However, these peers cannot go on to actually give the services that is needed. For example, they may give the information, but they may not be able to give the injection. They may give the information, but they will not be able to insert the ring in a lady's vagina and all that. So you find that they will do their best at giving information, but then when the young people go on to actually receive the actual services, they may not be able to receive it because of the negative attitude they will receive from the elder healthy care workers. So in my country, you find that if we have services like at the youth centers, there are specific youth centers where they are well known that they provide sexual reproductive health services. So even if you go there when you're a young person, you receive whatever service you need to receive, whether from an old person or a young person. But when you go to the government centers or these NGO-led centers, the kind of friendliness that you receive from the health workers is totally different. So how I wish we have trainings, not to train specifically one focal person at the health facility who is responsible for family planning, but to train the entire healthy workers, because our kinds of health systems, health workers rotate. Today you find one health worker in maternity, tomorrow you find them in OPD. So you need to train the entire healthy unit so that even if there is some kind of switching or someone has left the facility, there will not be any gap in terms of providing these services to young people who need them. Yeah.
Great.
And the other barrier that I see is that young people usually they want to use condoms, yes, because condoms will prevent the pregnancy. It will also prevent the STIs, including HIV. But you only have an option of a condom. So how I wish there were very many options. For example, probably if there was a vaginal ring that could be used to prevent HIV, but at the same time prevent pregnancy, so that one does not have to have two kinds of how should I call them, commodities to use. They have to use one commodity for both STIs and also pregnancy. Thank you so much.
Josephine, I'm so glad you brought that up. You get extra credit points for bringing the Dipivering ring into the conversation so early. Maybe with that, I'll go straight to you, Yvette, because I actually know that you were just on another webinar talking about the Dipivering vaginal ring. Just a couple of thoughts, barriers, and what you need, and perhaps what do we need to do about the ring?
Thank you, Mitchell, and thanks everyone on the call for this opportunity. Just yesterday, I was on a radio interview, Mitchell, and I was taken aback by a person, Stembiso, whom many of us know here, calling in and saying to me, Yvette, I don't know stigma anymore. I only know human rights violations. So what is currently the biggest barrier is human rights violations in many countries across the world is access to health care, a human right. So we continuing using soft words and saying it's stigma, but stigma in itself is such a barrier that the young people that we work with, the ground forces we work with, when they go to clinics and like Josephine was saying, getting access and trying to get access to SRH, going there as a young person asking many questions. Often I turn back, why are you asking about condoms? You are only this age, why are you doing that? So I think we need to think about how stigma becomes a human rights violation when young people and the numbers of people living with getting infected with HIV, how that has an effect and actually deprive them from their human rights. So young people cannot access commodities. I don't even want to go into the issue around COVID-19 and how that affected us. We warned governments, we spoke to governments, integrate, give young people the methods, HIV prevention methods, the contraceptive methods long enough, because we do not know where we are going with this disease that we did not know what it looked like, how it's transmitted. And governments did not listen. Healthcare workers and healthcare policymakers did not listen. And we are sitting with something dire in South Africa that we have had at some point 10,000 people not going to fetch their medication. I don't blame them. It was scary to be out there again after a long time. So yes, let's talk about those things and actually consult with young people, consult with women to say, and I'm glad for the call to action, and I'm glad about the work that Margaret Happy was doing with FP2020 and IAS around how to do this call to action and what are the things that women want when they go to clinics. I say, when I go to a public health care center, I want to just be treated as Yvette. I want to arrive there with a status neutral visit. Nobody must tell me the pink cards go there. Oh, those ones who want, and it's as loud as those ones who came here for the injection, that way and that way. Can we please just be kind to women so that women embrace their sexual health?
Beautifully said, Yvette. I feel like that last line is where we might want to come back. I hope you say it again at the very end of this call, because that's the beautiful line to end on. Helen, you were shaking your head affirmatively in both what Yvette said as well as when Josephine was talking particularly about providers. So I'd love to hear, the barrier from your perspective and the opportunity that you might see.
Yeah, I think I'm going to say 2 C's as well. I mean, I think one of the big barriers I say from the provider, from the system side of things, is communication. So communication between the sexual health department and the HIV department. How can we bring that together? This silo, people put in the word cloud. a siloed approach. So improving that communication between the two departments is absolutely key to the barrier and the solution, I think. And yeah, hearing what Josephine and Yvette have been saying, commodities, time and time again, even where there's systems in place to integrate, there's willingness to integrate those commodities, and particularly, unfortunately, the FP commodity, the family planning commodities, simply aren't there. Certainly in some of the programs I've been working with over the years, you know, often, you know, those commodities are just simply out of stock. So yeah, communication and having those commodities insured on the shelf. Without that, integration isn't going to happen. And I love Josephine's integrated prevention of both HIV and pregnancy. That's going to be the dream going forward. Yeah.
Absolutely. I think we're going to get, hopefully, to talk a bit about multi-purpose products. We already have 2 male and female condoms. We clearly need more. And we'll talk about commodities and the way we communicate. But first, I want to actually swing back to Uganda, to Margaret Happy. Margaret, you with the ECHO, GCAG, and then your role on the community of practice in developing this call to action. Would love just to hear, before we go to the first poll for everybody to engage, would love to get your view, having participated in all of this. What aren't we getting right? We say we have all these right ideas. What's not working yet? And Margaret, if you're talking, you're on mute.
Micho, I think to me, can you hear me?
Yes, now we can.
None of my video was net for. Yeah, what we are not doing well or right at the moment is having siloed funding. We are having funding gaps for reproductive health commodities. And I would like to give an example of Uganda. I love analyzing budgets. And from that, it will guide us whether we are doing it right or not, or whether I'm answering the question you've just asked. According to our financial year, 2020, 2021 here in Uganda, when you look at our national budget, you will realize that we don't have funding gap for ARVs, for instance, if I focus on the commodities. But for reproductive health commodities, we have around 62% of our funding gap. And in this case, I'm looking at delivery kits, I'm looking at contraceptives. And then when you look at the government of Uganda's commitment towards ARVs, comparing the previous financial year and the current financial year's national budget, you will realize that we've had an increase in the funding from our government from 19% to 30%, and that's excellent. But when it comes to reproductive health commodities, you will realize that we had a reduction from 15% to 19%. So in this case, I want to say that we are not doing it right. And so if we could only focus on ensuring that we have enabling funding, legal, and a policy environment, then integration of sexual and reproductive health and HIV would be a reality. And now that we're even talking about COVID-19, we need to put our emphasis around ensuring that we have enabling funding, we have enabling policy and legal environment to respond to those challenges. But at the same time, another thing that I would like to look at is having the health system that supports SRH HIV integration. And that is where we still have a big problem. But if we work around that, having supportive health systems, then we would be doing it right. And this call, the global call to action, requires supportive health systems for ensuring that we have integrated SRH and HIV. And then we need integrated service delivery points. And I'm so glad that in Uganda, for instance, we are taking up some baby steps, some positive baby steps. Especially when I look at differentiated service delivery, it's implemented in Uganda. And I want to say that amidst COVID-19 era, DSD is taking its roots. And I want to appreciate PEPFAR, for instance, in Uganda. It's actually funding communities to ensure that we use the community delivery models. The differentiated community delivery models are taking shape. And so I would like to encourage different countries to emphasize, to put a lot of emphasis in terms of resources, policies, and legal environment to facilitate implementation of community-based service delivery models, because self-care and community-based models are critical, especially in this era of COVID. Mitch, I have a lot I can say about this, but I know with time, you can guide me whether I should continue or not. But
I'm going to pause you there. I'm not stopping you. I'm just going to pause you there to go to our first poll. I do want to say how great it is. Both, there's a lot that isn't working, but I love that you highlighted what is working. And I think that's what we're all grappling with. What are some experiences and lessons? And your example in Uganda is a great one. And want to also thank you. Advocates we often call for more money. I think what you've done, though, is show us what real strategic advocacy looks like by doing that budget analysis to drive that thinking. So we'll come back to all of this. Want to quickly go to everybody on the line with our first poll that I think is going to magically come up on your screen. There it is. In your setting, where is SRH and HIV care integrated? And you can click all that apply. And if it's nowhere in your setting, say that too. So I'm going to keep going while people fill out the poll, and those numbers are going to pop up, I think, in a minute. Let's see, but we'll keep going. There's a question that came up early on that I think is really important to grapple with, and it came up in a couple of different questions. Some of it's about language and some of it's about audience. We talk a lot about adolescent girls and young women, and we talk a lot about family planning and HIV. But a number of comments and questions came in. What about boys and young men? And should we be talking less about FP and HIV and more about sex and sexuality? And I'd love to hear any of the four of you weigh in on that. Anyone want to kick us off on that? Not to put you on the spot, Yvette, but I know you and I have talked about this a lot. What's your thought?
Yes, Mitchell, it is a long way coming. That the burden of family planning, the burden of SRHR lies on young women. If men and boys want to take it up, we welcome that. And always analyzing as an activist, and somebody was saying a woman can only take 9 months to stay pregnant and raise a child, while a man can actually impregnate 1,000 women over the years. So we would welcome that. Let's get the boys in the room. Let's get young men in the understanding of what SRHR means for them and means for planning of pregnancies. I don't like to say family planning, but that's the word. Let's think about how to integrate the male voices too. However, we must remember that unfortunately, women carry that burden, that we almost like a catchment area. As I was filling in the poll right now, I just saw that antenatal. I can't escape that. Whether I like it or not, I don't have a choice. When I get there, if I'm HIV positive, I am in a catchment audience, and somebody catches me, gives me HIV ARVs, and makes me feel bad about the baby and all of that. So we need to actually integrate young men very early in planning of pregnancies and understanding sexual and reproductive health rights. They also have a right, and we need to start talking to them, but we must also be very, very careful that we do not promote some of the decision makings of women, give that over to men and young boys, but let them understand their own sexual and reproductive health rights.
No, that's fantastic. And here we have the poll. And hopefully it's all popping up on your screen. We see clearly a focus on antenatal clinics, followed not too far behind by ART clinics. Oh, and family planning clinics down there at 60%. I wonder, Helen, as someone who thinks about this at the implementation level, as you look at these poll results, surprised, missed opportunities? Are there things that
Yeah, no, really interesting. In fact, I'm maybe a little bit positively surprised, but still less than half of ART clinics being able to offer family planning. And I think the real challenge, one of the bigger challenges as we go forward, and again, I'm going to come back to how the SRH teams are communicating with the HIV teams, is with differentiated service delivery over the last 5 years or so. We've seen countries really scale this up, and now we're seeing what differentiated service delivery has meant is that women are coming less often, both for clinical visits and for ART refills to the clinic. Many of the models are in the community, so in some instances they need to come once a year. So it's not just about how we provide that contraceptive care in the ART clinic, but in the context of some of these models, where we're giving 6 months of ART, how do we integrate into those models as well? And that, that might be about policies. Is there a policy that allows us to align if a woman has chosen pills or depot? How do we align that? Are we allowed to also give 6 months of pills? And does our supply chain allow us to do that? So I think, the fact that less than half of ART clinics aren't thinking about family planning, I think, there's clearly work for us to do. But I think, it's not just at the facility. Think about our community models. Are there opportunities to deliver family planning in the similar way through those community models? And let's utilize those opportunities. Also, some of which will enable self-management and really kind of empower women to self-manage.
Yeah, and that's really helpful. I wonder, Justine, I saw your camera came on. I hope that means you were gonna jump in as well.
Mita, can I weigh in?
Oh, go ahead, Margaret.
Thank you so much. Actually, I'm not surprised by the poll results because I see antenatal care has got the highest percentage, 64.3. Oh, good. Oh, God. But I think I want to re-emphasize what Beth shared with us, the rights-based component of it. Because I would like to use the example, the case of Uganda. Every pregnant woman who visits antenatal care clinic, she has to also go for HIV testing. And of course, it's provider initiated. But what we are saying here is that we need to ensure that the rights of the people who are supposed to access HIV testing at the antenatal care clinics must be respected. Women must not be coerced or subjected to HIV testing when they go for antenatal care clinics. They should be provided with full information so that they make informed decision to undergo HIV testing. The reason why I'm emphasizing on the rights of mothers, of the pregnant women, is that we are having many mothers who get initiated on treatment. Immediately they attend antenatal care clinics, they are tested HIV, they undergo HIV testing, and then they deliver. Once they have delivered, then the mothers disappear. So for us to prevent cases of loss to follow up of mothers who undergo HIV testing, but also get initiated on treatment, given the test and treat, we need to provide them full information so that they make informed decision whether or not they are ready to be initiated on treatment. The same applies to the family planning clinic, which has ranked second. The family planning clinics, and I would like to use the case of Uganda, where I visited one of the facilities, and I actually realized that there was some kind of violation. A mother testified that she went to the family planning clinic, but she was denied access to the commodities unless she underwent HIV testing. So what I'm trying to say is that as we do the integration, we must be conscious about rights-based service delivery, rights-based programming for HIV and SRH care.
Beautiful. Margaret, thank you so much for that. A great question just came in actually from Megan Christofield that I wanted maybe to come back to you, Josephine. You talked about the importance of providers and the training. And Megan rightly points out that sometimes we can demonize health workers, and we do recognize the enormous demands placed on them and pressures, whether from their own employers or from donors to reach certain targets. And she's asking, is there a way that we can change provider behavior by uplifting them in a positive way? And I wonder, Josephine, if you have some thoughts of what, because you said at the beginning about that role of the provider, but would love to hear how we might work with providers as a partner in all of this in a positive way. Any thoughts on that?
Yes, thank you so much. Definitely, when I say that some health workers have negative attitudes, it doesn't mean that every health worker has a negative attitude. You may go to a healthy facility and you actually find that young people only want to go to a certain room, and they know that that's the doctor that understands them. But there are probably like 5 rooms and they don't want to go there. So what happens if tomorrow, probably that doctor is not available in that clinic? What will happen to all these young people that prefer to go to that doctor? So we could do some kinds of rewarding, you know, like appreciate some of our health workers that are really doing a very good work to ensuring that they serve the needs of young people and they serve them non-judgmentally, so that probably it can entice and motivate even the other healthy workers to ensure that they do a similar work or they copy certain characters from such healthy workers. And also, how do we ensure that if we are doing a training, I've seen it several times, that when probably an implementing partner is carrying out a training, they'll always carry one person, the same person in each training. But our kind of system, really, that person will be there, and before you know it, the government will ask for a shift or a switch, and they'll be taken somewhere else. So how do we ensure that in all trainings we have all healthy workers involved? It may not be a training whether you're calling all health workers to go to a hotel and participate, because the facility will be left with no person at all. But it could be a training that is incorporated into CMEs. That way you have the attendance of most of the health workers in those very facilities. And we all know that we have some model clinics that have shown us that actually they are doing very good work when it comes to providing sexual reproductive information and services to young people. So how do we copy what is happening in such model clinics to ensure that all clinics or all healthy facilities within the country are doing the same work?
It's great. And I wonder, I now think maybe we need to add a 5th part of our call to action of really rewarding positive behaviors, because there have been important policy changes. I think, as Anna showed, the UNAIDS report just out, they integrated the integration target into the 2025. We should be celebrating progress when it happens, not only calling out when it doesn't. And I do want to maybe bring up our other poll question. I don't think appreciation of health workers has ever been more important than as we grapple with COVID. And it's hard to have a conversation in 2020 and not think about the impact of COVID, but also the opportunities for differentiated services. So you can see on your screen, hopefully now, 2 questions. What's been the impact of COVID-19 on SRHR and HIV integration? And 2, what are the opportunities for that integration? And you'll see a bunch of choices there. As people begin to answer them, I wonder if anyone on the panel wants to also throw in their thoughts on the impact and opportunities of COVID as you're seeing it in your settings. Anyone on the panel want to provide a perspective?
Yes, Micho?
Okay.
Yes, go ahead.
This is Margaret from Uganda. I see one big opportunity, for instance, in the case of Uganda. Right now, we are in the process of national planning and budgeting for the financial year 2021-2022. And I see this as an opportunity for us to push for, or to shape and inform the budgeting and planning process to ensure that we have SRH, HIV integration considered in our budget, national budget, but also in the national plan, right from the national level, but also in all our local governments. So that is one of the big opportunity before us.
Great.
But in terms of the impact of COVID-19, it has worsened the SRH HIV integration, because the extent to which, for instance, people living with HIV have been visiting the facilities have also reduced. So when I look at the DSD models, especially where we have the facility-based differentiated service delivery models, the clients who used to go to the facilities under a fast track model, they now get their medicines delivered to their homes. For instance, I got my drugs, my ARVs delivered to my home. But if I wanted family planning method also to be delivered with my ARVs, I would have missed that opportunity, because the health worker did not even call me to ask me about contraceptives, except they called me to inform me that someone was delivering my ARVs. So, so that is an area that we need also to, we need to focus on when we talk about integration.
Fabulous, Margaret. Thank you so much. Helen, were you going to add to that?
Yeah, I think what we've seen over these difficult few months, and I want to kind of concentrate on those opportunities, because certainly from the ART side of things, we've seen policy barriers knocked down that we've been kind of pushing for years. Countries that were only giving 1 month of ART suddenly happy to give 6 months of ART. And I would just challenge as well, how about looking at those same policy barriers when we're thinking about family planning commodities, and pushing, as Margaret says, how do we ensure the funding to make sure they're on the shelf to be able to match and align those commodities with the ART. But I think as we've seen those policy barriers knocked down because of COVID, let's learn, let's see how things have gone in terms of retention. But also let's not suddenly go back. Can we go forward with that? So I really have seen some opportunities, and I'd love to see how we can align the family planning provision with those opportunities of move forward, maybe with some of the ART changes during COVID.
Yeah, no, I think that alignment of product and of program, as you're describing it, some of which is beginning perhaps because of COVID. How do we make sure that we take the advances that came in an emergency and have them stick? Really important. I know we're coming up near the end of time, and just really remarkable questions and comments. I wonder, Josephine and Yvette, just to see very quickly, any additional thoughts, particularly in this moment, of how do we bring it all together, and how do we go forward out of this webinar? As Beth said, we've had a lot of these conversations. What next? And so maybe Josephine and Yvette, just to give you a chance to give some thoughts on that.
Thank you so much. I would regret if I left this platform without making this statement. I think as we plan on integrating HIV and sexual reproductive health, both information and services, I think there is one key population, a category of people that we should also think about. And those are the people that are disabled, but at the same time, HIV positive. Because several times there is a thought of they are not sexually active, but sometimes some of them are sexually active. So when we are talking about integration of these services, I hope we can also factor in such people as a key category that we should not leave behind on our agenda. Thank you.
That's great. Leave no one behind is a clarion call for all of our work. It must be. Yvette?
As more methods become available, let's think about making it all accessible to women, and let's give them an option of choice to choose from. I just, like Josephine, I also have a parting shot. Imagine a young boy going for his very first driving lessons, and right there they catch him and they say, let's give you something called SRHR. Can you imagine how uncomfortable that would be? So when we think about how, like Margaret Happy mentioned, how young women and women, when they get pregnant, go to the clinics and have to deal with pregnancy, then all of these things are thrown onto them. Let's think how that feels. So maybe when a boy buys his first car, we say, did you do your HIV test? Let's test you. Did you do this? And let's do that. So that that is all about equality and making sure we also grab the young men and boys when it's very early. Thank you.
No, thank you. Thank you all four for highlighting critical issues and opportunities. And I will say one of the things that I find inspiring is that in a year that has been unlike any imaginable and one we all look forward to ending, there are opportunities. I'm reminded of a beautiful poem. There's a crack in everything. That's how the light gets in. And there have been more cracks than any of us could bear to think about this year, but we have opportunities to collaborate, synchronizing and aligning commodities, changing training to create a whole new cadre of empathetic health workers and support systems for young men and young women to get what they need, when they need it, where they need it. And I look forward to working with the four of you with the IAS, with FP 2020, and just really want to thank you. And the conversation doesn't end here. I'm going to turn it back to Anna and to close us out and to talk about ways forward.
Thanks so much, Mitchell. I couldn't be happier that you ended with a Canadian Leonard Cohen quote, so thanks for that.
Well spotted.
I want to make a brief plug for those of you who are researchers and academics and implementers and also recipients of care for two places that are looking for your research in relation to these topics. So please check out the Journal of the International AIDS Society special issue on differentiated service delivery and the impact of COVID-19. And also please look at the Frontiers in Global Women's Health Call for Submissions for Integrated HIV and Family Planning Care. Both of these journals are looking for abstracts that are due in January. And on to the next slide. We obviously want to make sure that you join us in action, that you visit srhintegration.org, and that you promote this call to action. As Beth said, they want to grow this community, and we're very excited to have you all as part of this community. And so all that's left for me now to do is to say thank you to FP 2020 and thank you to all the panelists and discussants today, as well as to our funders for making this possible. So thank you to the Bill and Melinda Gates Foundation, to FCDO, formerly DFID, to USAID, UNFPA, the Swiss Agency for Development and Cooperation, and Merck Sharp and Doan. We are very glad that you all joined us. Have a great day further, and we'll see you for more virtual platforms. Thanks, everyone. Bye.
Thanks, Anna. Thanks, everyone.